Now coming to traumatic retinal detachment, 11% of the dermatogenous retinal detachment are because of trauma. And most of this, as we are aware, trauma is mostly profession or sports related, and naturally it happens in a younger males. In retinal detachment, once you have a trauma, except in a case of a perforating injury, most of the blunt injuries manifest a retinal detachment not as an acute presentation but as a late presentation. 80% of the detachments in these cases of blunt injuries present about within the 2 years after the injuries. As I said, because the trauma happens in a younger patients, it's sport and work related, it happens in younger patients, and in these cases vitreous is formed and there is no posterior vitreous detachment. 28% of the patient had myopia, and the type of a breaks either can be a giant retinal tear or a dialysis. So depending on the type of injuries, like following contusion or an open globe injury, the detachment can be of a bit different type. The breaks can be of different nature. Dr. Murali has very well covered how the different types of breaks happen, so I would not be delving on it. But in a blunt injury, you can have in majority of 53% of the patient with a detachment have retinal dialysis, 16% of them tend to have giant retinal tears, and 11% can have horseshoe tears. And they already coup and counter coup injuries, Dr. Muralidhar has already spoken, so I would run through it and how the mechanism it happens, it's already elicited over here. So the importance over here is that in majority of the cases, there is a window after a case of a blunt injury. There is a development of break, and it takes few weeks to months before it precipitates as a retinal detachment, and thereby the importance of doing a detailed indirect ophthalmoscopy right up to the pars plana, and there you can prevent the patient to have a retinal detachment. But yes, if the patient presents to you late, fine, then the treatment is either a buckle or a vitrectomy depending on the configuration. Avulsion of vitreous base already Dr. Murali has covered up, so I would not be speaking on it. In cases of penetrating injury, because of the rupture of the sclera, the mechanism is going to be different. Here, because of the rupture of the coats, there would be a break in the chorioretinal complex over there. That can be the cause of a break. Or sometimes, because of the break in the blood retinal barrier, the cells might proliferate and might have a limited proliferation in and around the site of injury. And the third is fibrovascular ingrowth. And this is the worst form of detachments you have, and it really have a bad prognosis if not tackled earlier. Once you have a case of a detachment, the two basic investigations are necessary are B scan and radiological investigation in the form of CT scans. B scan is done if the media is hazy, where you cannot pick up there is a detachment as you have a vitreous hemorrhage, or if there is an endophthalmitis associated with it, or you are suspecting an associated foreign body, or sometimes when you want to understand the vitreoretinal relationship and where to how to induce a PVD and all, what is the status of PVD. This is important for a vitreoretinal surgeon before he enters inside the eye. CT scan orbit is rarely needed. The only need of CT scan costly investigation like CT scan is in case when you are suspecting a posterior scleral tear and you are not sure clinically, where you can get a flat tire sign, or if you are suspecting a very small foreign body which might have lodged in that case, or you are suspecting an associated orbital wall fractures. These are the only three indications of doing a costly investigation like CT scan. Once you have a detachment and the patient presents, you have two ways of approaching it. You need to do, you can do a scleral buckling or a vitreous surgery. Scleral buckling is usually a procedure of choice if the breaks are quite posterior, there is a 1 or 2 quadrant detachment, and a patient is young, because in these patients, being a young patient, the vitreous is very densely adherent, and that is why induction of PVD in itself can lead to more iatrogenic problems. And buckle is definitely a predictable procedure even in these cases. As Dr. Vishal has shown in his slide, a primary scleral buckle along with wound repair. If you have a scleral repair, sclerocoroidal tear in the posterior beyond 3 millimeter behind the limbus, means it is encroaching into the pars plana or into the retina. In such cases, there is a concept of putting an encircling band or a buckle supporting that area of the tear along with a buckle. And it has shown that if you put a buckle along with primary repair, it reduces the risk of subsequent retinal detachment, and few of the studies have also shown improved final visual and anatomical outcome. Most of the patients which present to us with a rhegmatogenous retinal detachment have severe PVR, and the severe PVR is basically why? Because of the injury, be it a blunt or a perforating, there is a break in blood retinal barrier. The presence of subretinal or a vitreous hemorrhage can lead to more severe PVR. The breaks can be bigger, usually a dialysis or a giant retinal tear, leading to more exposure of a retinal pigment epithelial cells, and scleral rupture leading to ingrowth. And if the patients present to you with a severe PVR, you have no other option but to go for a vitreous surgery. Vitreous surgery, you need to do a vitrectomy followed by PVD induction, and then you have to look at the associated collateral damage in the form of, if there is a foreign body, you need to manage that. If there is a hemorrhage, you need to manage it, and accordingly. Now the question comes, when do we do a vitreous surgery in a case of a detachment along with primary repair or as a planned procedure? You are forced to do, if you have a detachment, as a detachment, usually as a vitreoretinal surgeon in a trauma case, you would like to do it as a planned procedure. But you might have to do it as a primary, along with primary repair, only in these three circumstances: when there is an organic foreign body which can further lead to severe endophthalmitis like reaction, or if the patient has associated endophthalmitis, or there is a detachment. Planned vitrectomy usually is preferred. Why? Basically because of the media clarity, the ocular stability, and there is no wound lake. And other most important advantage of doing a planned procedure is that after 2 weeks following a surgery, there is a PVD induction. So 2 to 3 weeks following, if you get that window, PVD induction happens spontaneously following a trauma, and that's why it makes your life more easier. Surgical management of traumatic RD with perfluorocarbon. This Vitreon study has very clearly shown that a reattachment rate of as high as 76%, with 50% of the patient having more than 5/200 vision, can be achieved. So it means it has a good success rate. Similarly, doing a vitrectomy along with a buckle, the success rate, reattachment rate, can be as high as 78%, with a functional success of 57%. These are the factors which decide the visual recovery following a vitreous surgery. That depends upon the wound location, presence or absence of vitreous prolapse, associated infection, that is endophthalmitis, whether you are using scleral buckling or encircling band as a primary procedure, whether you need to use a gas or an oil, whether you had to use a lensectomy, and the presence or absence of a foreign body. Most of the detachment cases, in this case, let us understand that this single surgery is not possible. This is a video where you will see, this is a case of post-repair. He has a traumatic cataract, wound repair was done elsewhere. The patient is referred to us for further management. He had an endophthalmitis at this point of time. So we do a lensectomy, and he had a endophthalmitis, so we did a vitrectomy for him. A core vitrectomy was done. This is a case of a perforating injury, as you see, treated along with intravitreal antibiotics. Now we were happy that this patient would come out very well, and yes, he did behave well for a month. But yes, because of the injuries, or might be because of endophthalmitis, there is a necrosis of retinal tissues, which leads to tears and thereby detachment. So after a month, we had a detachment. Here you see a severe fibrovascular ingrowth, which we had to actually cut with a vitreous scissor. And this retina was settled after pure PFCL silicone oil exchange with a silicone oil. And in most of these cases, because of a severe fibrovascular proliferation, we might have to do a lot of T-shirt. Retina might be very hard, fibrotic, and we may need to do a retinectomy. Again, after 2 months, we had a minimal recurrence, and again we need to do. So the moral of the story of this video is that in a case of an injury, it is not a single surgery most of the times. Many of these cases, if you want to give the result, might end up needing 2 or 3 surgeries. But yes, if you persist with the treatment, and if the patient continues with you, definitely you can end up, as in this patient had a final visual acuity of 6/24. Thank you.